Hello, and welcome to this second in a series on patient autonomy, where we're going to take a look at medical cannabis and ask the question: is this a dangerous and illicit drug, and or possibly both? Is this a reemerging herbal remedy? And so, to take a look at this in context, about half of our current medications, about half of the medications that you can go both prescription and over the counter, are based at least at some level on plant extracts. And so some different examples of this. Along the first portion of the slide, we've got a willow tree here. Within the willow tree, mainly from the bark or the leaves, picking tea from the leaves, you can isolate salicylic acid, which is the main active ingredient for aspirin. Now, it's estimated, kind of historically, that it was first used about 3000 BCE. So, roughly 5,000 years ago, there's evidence that this willow bark or willow leaves have been used as an anti-inflammatory and pain reliever. Now we don't have to go to a willow tree. We can, go to the pharmacy or even to the grocery store and pick up aspirin. Another example of this, in the middle here, we've got a star anise plant. This is a Chinese plant. It's used as a spice, but in addition to that, it's got a molecule within it called L-sutamivir. This was identified in the 1990s and has been kind of developed into this oral antiviral treatment, and it serves as the basis for Tamiflu. And so basically an antiviral treatment to treat influenza. And then over here, we've got a Pacific yew plant. This is an evergreen, a conifer over here. Within this is going to be another biological molecule, pacitivol, which has been derived into Taxol. This was identified originally in the 1960s as an antimitotic agent, which basically means that it, stops the dividing of cells. And so for an individual that has a cancerous tumor, it has cancerous cells, the cancer is formed by, cells dividing uncontrollably. And so treatment with Taxol, derived from the bark from the Pacific yew tree, is a fairly potent treatment for certain types of cancer. So moving from that, looking specifically at cannabis sativa. Cannabis sativa is a plant that has been used and cultivated for at least 6,000 years, going back, about kind of contemporary of our willow tree here, generating aspirin. And at about the same period of time, maybe in a different region of the world, we can find evidence that the cannabis plant was being cultivated. Now, this plant has a lot of potential purposes or uses associated with it. The stem is used for generation of hemp fibers. Those hemp fibers, kind of more recently, have been looked at as a construction material, potentially to be using this to reinforce concrete. And there's also studies going on right now looking at the effect of whether or not we can generate plastics from these hemp stems, these hemp fibers, rather than from the petroleum products, the oil products in essence. There's also an interest in using cannabis stems as a biofuel. The flowers, and we can see a flower over here, is the medicinal part of the plant. Within this, these are the regions that are used for generating the medicinal and herbal remedies. The seeds are used to generate hemp oil, which is rich in beneficial fatty acids. And so because of that, it's been used in both human foods and animal foods. And then finally, there are efforts to at least grow some of these plants, ideally the low THC versions we'll talk about in a couple minutes, but using these entire plants for erosion control, They have a very strong root structure. Will hold the soil together and minimize the soil runoff during floods and rains and things like that. And then because it is also a fairly fast grower, it's being thought about as a location where we can store CO2. And so get CO2 out of the atmosphere and into a biological molecule or biological plant. Now, if we take a look at this, again, thinking about this as a potential herbal remedy, the two most abundant of the bioactive molecules in cannabis are THC, which is known by its full name, delta-9 tetrahydrocannabinol. And this is going to be the psychoactive ingredient. This is the ingredient that basically kind of impacts kind of the function of the brain and can contribute to short-term memory impairment, spatial memory problems. It can also contribute to a whole variety of other things, examples of this on the slide. The second of the molecules, CBD, cannabidiol, is a molecule that doesn't have the psychoactive effects. It doesn't cause the kind of memory effects that you would see with THC, but it has some other effects as its own. And one of those effects is that it can actually balance out the effects of THC. And so the interactions of THC and CBD can potentiate or control the pharmacological benefits or effects of this. And so what we can see on this slide, kind of representing some of the effects of both THC and cannabis in terms of pain relief, anti-nociceptive. Nociception is pain, so anti-nociception is going to be pain relief. Good, strong effect by THC, moderate effect in CBD, the cannabidiol. The psychotropic, the kind of cognitive effects, the psychoactive effects, very strong with THC, minimal, if at all, with CBD. Both of them, actually not both of them, maybe some effect from THC in terms of treating anxiety, much bigger effect in terms of CBD. THC has its sedation effects. And then again, showing this kind of antagonistic control that the CBD and THC often has. If we take a look at something like the heart rate, THC will speed up the heart rate, where CBD will slow it down. And in general, THC is going to raise appetite, where CBD is going to lower it. And then because of one of the very prominent uses of medical cannabis, THC also is beneficial for appetite, especially with cancer patients that are having a hard time eating. Now, in addition to THC and CBD as the prominent and most abundant bioactive molecules in cannabis, there are at least another 200 bioactive molecules that are going to be present in cannabis. And that, again, gives rise to the difficulty in using botanicals, plants, as a medicinal source, is that there's a lot of variability that is going to be present within them. So we've got other types of cannabinoids kind of related to THC and CBD, each of which has differing effects on the body. We've got terpenes, another class of molecule which is going to be present. Things like myrcene that we can see here. This is the most abundant of the terpenes. Has a sedative effect within animal studies. Pinene, alpha-pinene is actually, it's still abundant within cannabis, but it's going to be the most abundant of the terpenes in nature. So you can find this in a whole variety of other types of plants. It appears to have an effect in treating and reducing anxiety, and it also appears to act within the nervous system in a way that is very similar to the binding of the drug Xanax. And so, some potential benefits for using pinene as a source as well. Carotene over here, an anti-inflammatory agent. And so, kind of minimizing kind of the response you would see with kind of an injury or disease process occurring. Now, in all of these examples, there's very limited evidence to the effects of these, potential drugs, mainly on animal studies at this point, because there have been very limited studies on the effects of these agents on human beings. And so if we take a look at this, try to understand, oops, I apologize for that. Going backwards in the slides. Okay. So try again. And so we've got these agents, we've got these chemicals that are found within cannabis. And even though they've been isolated, I think THC was originally isolated in the 1960s and characterized. It wasn't until 1988 that the endocannabinoid system was discovered. This is an endogenous system within our body that responds to cannabis-like molecules similar to THC and CBD that are found intrinsically within the body. And so, again, discovered just about 35 years ago now. But as more and more is learned about this, it's becoming more and more important. And it's thought that this endocannabinoid system, this normal system found within our body, serves as a very important bridge between the brain and our physical health and disease. Again, with further research, they were able to identify two sets of receptors, a CB1 receptor, so cannabinoid 1, and CB2, cannabinoid 2 receptors. These are going to be the molecules that are present on the surface of cells that bind to the chemical signals, that bind to the messengers, and kind of determine how that cell is going to be able to respond. Now, CB1 is going to be found in a whole variety of areas of the brain and the spinal cord, primarily within the central nervous system. And this appears to have an effect on executive decision making, emotional reactions, and feeding, as well as the psychoactive effects, reduction of pain, and stimulation of the appetite. The other type of receptors, the CB2 receptors, and now in this slide, make sure I can see this right, the black are going to be examples of locations where we find both types of these receptors. The blue primarily within the central nervous system, and then the red kind of out within the periphery of the body. So you can find these throughout the body, oftentimes on immune system cells. So cells involved with kind of regulating your body's response against disease, as well as controlling inflammation. And so it's thought to be very, very important, especially at maintaining the kind of internal balance within the body, this internal, what's referred to as homeostasis within the body. Now, if we take a look at this, it was originally identified by the ability to bind to THC, but they've been able to determine that there are actually endogenous molecules that are produced in our body that act normally on our endocannabinoid system to regulate the activity, primarily within the nervous system, but to regulate the kind of normal kind of control and kind of levels of activity within our body. And so we've got two examples of this. And I know I'm going to mispronounce this one. Make sure I get the slide right. AEA over here is anandamide, named for the Sanskrit word for bliss. And this is basically kind of a molecule that we can find within the body normally. A related molecule, this 2-AG, again, acts at the regions within the endocannabinoid system. And so what we see normally going on over here, and this is similar to the slides we've seen previously, we've got a sending cell over here, we've got a receiving cell over here, and that sending cell, that sending nerve cell, in order to send a message to cause something to go on within the nervous system, is going to release these chemicals, these signaling molecules. They're going to bind to receptors on that target cell. Now that target cell is going to release some of those endocannabinoids, the AEA or the 2-AG, and they're going to go back and they're going to control the activity of that sending cell to kind of regulate the amount of activity that's going to be present. And it's going to be very important for maintaining the kind of body, kind of at a normal set point, the normal kind of limits of different parameters within your body. Now, as better understanding of the endocannabinoid system was determined, in 2006, researchers had developed an antagonist to CB1. So an antagonist will go through and interfere with the activity of that receptor. And so there was good evidence that the endocannabinoids binding to the CB1 receptor would stimulate appetite. And so the idea was that if we could block the binding of the CB1 receptor, we could potentially limit the desire to eat, diminish the desire to eat. And so Ramanujan, I can't pronounce this, Raman Abend, however this is pronounced, was a drug approved kind of throughout the world, a variety of different names associated depending upon the country that was approved in, for weight loss. Never approved within the United States by the FDA. They wanted additional information because there was an incident, or not an incident, there was evidence that it would increase the risk of psychiatric disorders. As they studied that in more detail, they saw a pretty dramatic increase, a doubling in the risk associated with depression and suicidal ideation. And so because of that, this drug was withdrawn from the market in 2008. So indicating, again, the importance of these endogenous cannabinoid receptors on the body, because if we disrupt them, eliminate their activity completely, this can have very detrimental effects on the nervous system, in this case, causing depression and suicidal thoughts. Now, having said that, clinical endocannabinoid deficiency is a syndrome that is thought about right now as being linked to a number of conditions which are not well understood and have been resistant to treatment. And so one example of that is fibromyalgia. Fibromyalgia is a long-term chronic condition that causes pretty significant symptoms of pain, musculoskeletal pain, pain of the muscles of the bone, tenderness, generalized fatigue, as well as sleep and cognitive disturbances. And so in this 2016 paper here, taking a look at this kind of claim of clinical endocannabinoid deficiency in a variety of diseases, but then more recently, and this is coming out of an article published, double check this, in 2020, looking at kind of what would be your fibromyalgia impact questionnaire score along the y-axis here. So it's a series of questions. How much pain are you experiencing? How much discomfort are you experiencing? How much of this? How much of that? And a score of 0 means, basically no symptoms of fibromyalgia. A score of 100 up here would be, the absolute worst episode of fibromyalgia you can imagine, worst on each of the parameters that are looked at. Now, in this situation, they were looking at using a THC-rich cannabis oil for the treatment of fibromyalgia. And so we've got individuals over here that were treated with the THC-rich cannabis oil. Individuals over here treated with placebo. The blue is at the start of the study. And so you see that both groups of these individuals were, experiencing symptoms in the range of about 70 to 80. So relatively severe on the impact of fibromyalgia. But over time, treatment with this THC-rich oil resulted in these individuals here in this orange group from going in the range of about 75 down here into the range of about 30. And that is a significant reduction in the complications and the symptoms associated with fibromyalgia. In comparison, the individuals over here, my pointer back, a slight improvement, but it wasn't statistically significant. And so there was no improvement in placebo, but there was an improvement with treatment of the THC-rich oil for the treatment of fibromyalgia. So again, pretty strong evidence that the endocannabinoid system is involved with controlling a whole variety of things. And at least in this instance, in the case of fibromyalgia, evidence that kind of impairment in the normal endogenous system contributes to the disease. And if we can supplement it in some way, in this case by treating it with THC-rich cannabis oil, we can alleviate some of the symptoms associated with fibromyalgia, hopefully coming from this clinical endocannabinoid deficiency, and basically taking something that we haven't been able to understand and haven't been able to treat effectively, and potentially developing a treatment for that. Now, having said that, we still run into some controversy associated with it. Cannabis is recognized by the federal government, the Drug Enforcement Agency, the DEA, as a Schedule I drug. Basically, it is a drug with a risk of abuse, a risk of addiction with no accepted medical use. And so because of that, with this high potential for abuse, no accepted medical use, it basically is highly, highly restricted. In contrast, your over-the-counter medications would be a Schedule 5 down here. So taking a look at this, these are your over-the-counter medications, some of your prescription medications, but they have a low potential for abuse, but they have accepted medical use. And so, they are available. In between, Schedules 2, 3, and 4 are going to be a variety of medications that have some type of limited medical use, but there are some risks associated with it. Looking at some of the opioids, looking at some of the amphetamines, looking at some of the anti-anxiety and sleeping medications, subject to, a medical use, but a risk associated with them. And again, doctors need to, take a look at that risk-benefit analysis and discuss that with their patients. Now, we're seeing that, cannabis, like heroin and LSD and psilocybin, which I'll talk about in a couple minutes, are recognized as Schedule 1. But that's not always been the case. Cannabis actually was used pretty extensively throughout the 1800s and the early 1900s. It was included in the United States Pharmacopoeia, which is kind of a collection, a list of what medications are available and kind of describe their characteristics. And it was first described in that in 1850, so 170 years ago now. Federal kind of intervention on this, we saw the implementation of a marijuana tax in 1937, resulting in the first federal restrictions on cannabis use and sale. Ultimately, it was dropped in 1954 from the pharmacopoeia. The physicians at the time were concerned about their risk associated with, prescribing the drug. They had to have a special license to be able to do that, as well as they were not as convinced of the effectiveness of treating the conditions with this. Over time, the Boggs and Narcotic Act Control Acts of 1951 and 1956 implemented legal penalties for the possession of that. And so that was right about the same time it came off the pharmacopoeia. Ultimately, we got to the situation we are now with the Schedule 1 through 5 and cannabis being listed as a DEA Schedule 1. This was coming out of the Controlled Substances Act of 1970, which prohibits federally prohibits the growing, distribution, or use of cannabis. Now, having looked at this and then kind of recognizing some things we'll talk about on the next slide, in 2009, U.S. Attorney General Eric Holder indicated that enforcement of federal marijuana laws was not a priority in states, as I'm going to say in a minute, states with a medical cannabis program. And so he structured a program that provides medical cannabis, medical marijuana, under doctor's advice. So doctor's recommendation that the patient has a condition that would potentially benefit from treatment with cannabis, and has kind of the states that have those processes in place, they have the mechanism in place for delivering that. And so Holder said basically that in those states, we're not going to be enforcing the federal marijuana laws for the medical cannabis patients and providers. This was extended in 2013 with a Department of Justice memorandum to the U.S. attorneys, which basically said that the prosecution of individuals cultivating and distributing marijuana for medical purposes, now keep in mind this is all for medical purposes, is not identified as a federal priority. And so if you're doing it for non-medical purposes, you're still at risk from the federal government. And so if we're taking a look at this, and again, keep in mind that with any of these medications, whether we're talking about the over-the-counter medications, whether we're talking about the prescription drugs that your doctor will give to you, or things like cannabis, there are risks and benefits associated with it. And that's why you need to have an informed and educated discussion with your physician about what treatment and treatment strategies are going to be best for you. Now, in terms of cannabis, unsupervised cannabis use is associated with, as we said, a high risk of abuse, a risk of addiction, as well as some adverse effects. Some are going to be relatively short term, so you've got like a sedative effect. You can, got short term kind of impairment for learning and memory, but longer term use can result in kind of lower performance on some tests. Even though some individuals take it for the treatment of mental illness, there are thoughts that it could be contributing or at least exacerbating other types of mental illnesses. And it's associated with kind of a lack of motivation. So again, risks and benefits associated with it, and so it becomes incumbent on an individual to become informed of the risks and the possible benefits associated with it, and have a discussion with their clinician, with their physician. Now, if we take a look at this in terms of cannabis product, there are actually three either synthetic, and so they've kind of determined what the molecule was and determined a chemical process in which they can create it, or purified medications from a cannabis plant. Three of those have been approved by the FDA. The first, Marinol, under the generic name dronabinol. Cannot pronounce these things for the life of me. This is a synthetic form of THC that is used for the treatment of nausea and vomiting that's associated with chemotherapy. And so you see cancer patients that are having difficulty eating, taking something like this. Marinol is also prescribed for AIDS patients, patients with human immunodeficiency virus that have limited appetite. And so it has a recognized medicinal effect, has some risk of abuse associated with it, some risk of addiction. So this is an example of a Schedule 3. And so it's kind of midpoint on the DEA's schedule. So you can get this prescribed to you from a physician. This is available in a capsule, a tablet form, I think. Syndros over here is an oral form of dronabinol, so basically an oral form of the generic of Marinol. And so if we take a look at Syndros, this is for treatment of anorexic patients that don't respond to conventional anti-vomiting medications. This case, Syndros, an example of a Schedule 2. So a little bit higher risk of addiction associated with it, a little bit higher risk of abuse in its liquid form as opposed to the caplet form over here. And then finally, over here, we've got Epidiolex. And again, mispronouncing this badly, I apologize for that. This is an oral solution of CBD, so cannabidiol, with less than 0.1% THC. So both of these, Marinol, make sure we got it over. Marinol and Syndros have THC, which is the psychoactive ingredient within it. Epidiolex, however you pronounce it over here, is CBD without the THC. And so ideally, this is not going to have some of the psychoactive effects associated with it. This has been approved to treat 2 epilepsy conditions. So the seizures associated with Dravet syndrome and Lennox-Gastaut syndrome. And this, again, because it doesn't have THC, doesn't have the psychoactive agents, and has a very low risk of abuse, this is recognized as a Schedule 5. And so this is roughly equivalent to your prescription medications that you would go to the pharmacy with a prescription from your doctor and have it filled. Okay, so that's at the federal level. These are FDA approved for that. But then we're taking a look at what's available kind of outside of that realm, outside of those 3 synthetic or purified medications based on cannabis product. As of February 2022, 37 states and 4 territories have approved the medical use of cannabis under certain circumstances. So beginning in 1996, California was the first state to provide access to botanical cannabis. Cannabis is a plant, so it's a botanical medication for medicinal purposes under a physician's supervision for specific conditions, for specific diseases or conditions associated with it. And so if we take a look at this, so state-regulated cannabis programs, basically I'm going to have to glance over here to be able to see it. The darker green over here throughout the West Coast, a few kind of scattered through out here, have both medicinal use programs as well as adult use. Adult use is without the supervision of a physician. The lighter green that we see like Pennsylvania here and ultimately New Jersey coming along. Actually, no, I can't remember what New Jersey's at right now. But the kind of brighter green over here is a comprehensive medical program. And then finally, this lighter green is going to be low THC. And so this is primarily the CBD, the anti-anxiety effects, potentially the anti-inflammatory effects, without the effects of THC associated with it. All of these states have defined medical conditions in which a patient has to be defined and diagnosed as having had it. And then a recommending physician will review the medical record, interview the patient, and then certify them for admission to the state cannabis program. At that point, they'll usually get some type of identification, go to a medical marijuana dispensary, like a pharmacy, and select their cannabis products. Now, taking a look at this, raising this question in relationship to cannabis. Cannabis is an example of a Schedule I medication, no recognized medical use with a high risk of abuse and addiction. And take a look at another factor just to broaden this out a little bit. Psilocybin is a ingredient found within mushrooms. It's a psychedelic compound found in about a little over 200 species of fungi, but it's being looked at as a potential treatment for depression, PTSD, eating disorders, and addiction. And it acts similar to serotonin. It binds to serotonin receptors. Still, psilocybin, as an example of a psychedelic, is a Schedule I drug, federally restricted. But as of March 2022, we're seeing that there are going to be 91 registered clinical studies on clinicaltrials.gov that are looking at the effects of psilocybin for the treatment of a whole variety of things. Just glancing at it. Depression disorder, major depressive disorder, addiction, depression, Parkinson's disease. We've got a study here coming out in the Journal of the American Medical Association Psychiatry from Johns Hopkins University, looking at the effect of psilocybin-assisted therapy in major depressive disorders. And I think this one is 2021. And so an article about a year old now at this point, a randomized clinical trial showing that treatment with psilocybin is resulting in long-term improvement of depression symptoms, minimizing depression. Canada right now is in the process of kind of implementing psilocybin clinics. I think there's one or two now open. I think one's in Calgary. I don't remember where the other location is. It was approved about a year and a half ago. Still a lot of kind of mechanistic, a lot of procedural things that need to be worked out before it's available. But in November 2020, within the United States, Oregon passed Measure 109, giving legal access to psilocybin for medical treatments, and other cities, including the District of Columbia, Denver, Colorado, and Oakland, California, have again approved kind of localized medical treatment facilities with psilocybin. Now, at this point, I don't think any of them have opened up yet for direct access to patients, but we're seeing much greater research going on with this and the potential of opening up these clinics in the near future. There's actually one in Philadelphia that opened, I think, in the fall of 2021 that is approved now for treating, I think, depression with ketamine, another example of a scheduled drug, high subject to abuse, but treatment for depression there. And they're setting up so that if psilocybin is approved, they would be able to do that as well. So this gives rise to the ethical dilemma and science question for this week. We don't know whether or not cannabis affects some of these conditions. Because of the federal prohibition on access to the medication, it was very difficult for researchers to get access to the Schedule 1 substances. If we're taking a look at this as a botanical, cannabis has a wide variety of strains, and each one of those strains is going to have different concentrations of THC, CBD, as well as those terpenes and cannabinoids. And if we're looking at an interaction between them, we're just looking at the potential antagonistic effects of THC and CBD. If you're going to study the effects of these, medications, then they need to be standardized. It can't be kind of hit or miss. Sometimes you get a good batch of this, sometimes you don't get a good batch of that. And so you need to have access to, quality standardized properties. There's difficulty in recruiting subjects now that it's becoming a little bit easier to get access to these Schedule 1 substances, not always in its purified forms that we would need. Some studies have not been able to fill their subject pool because they've placed restrictions on activities. Some studies have prohibited driving while enrolled in the study. And so because of that has limited the amount of research that's been done on cannabis. And so a lot of the evidence is anecdotal or low quality evidence without the, nice, double-blind, placebo-controlled clinical trials, which we would ideally have. And so we're in a situation where it's illegal federally, allowed in certain states within medical programs. But how do we promote these high quality clinical trials to be able to give us the research into the benefits and risks of medical cannabis for specific conditions? How do we promote that in this kind of interesting time? Related to that, and again, related to the other questions in these areas of patient autonomy, is should patients have access to medical cannabis while the research is being conducted? How do you balance the desire of patients that want to use cannabis for these approved conditions by their states with a physician's need? You're going to be working with your physician to ideally maximize the benefits while minimizing the harmful interactions. And so if we don't have good, solid evidence, the clinical trials that we would normally have on FDA-approved medications, how do we know about what's going to be kind of going on and interacting with these patients that are treating themselves with medical cannabis under some level of supervision from a physician? We've got the FDA, the Food and Drug Administration, that needs to protect the public from harmful agents and misleading claims about the treatment benefits. And so they're doing a risk-benefit analysis, seeing a high risk of complications, high risk of abuse, with no defined or at least approved medical conditions right now. And so because of this, the FDA is not going to approve these for treatment. And then finally, even though we've seen that the federal government and the Drug Enforcement Agency are not putting it as a priority to enforce federal marijuana laws in regions with individuals using it for medical use, that could change at any point. And so, that is a major concern for patients as well as clinicians involved in these medical cannabis programs. And so lots of questions, and we need more answers. We need more evidence, more research in order to be able to determine what types, what strains, what molecules within cannabis could potentially have very beneficial effects for the treatments of diseases. We're seeing this, having been cultivated for 6,000 years and used in a whole variety of conditions as a herbal remedy. And it wouldn't be used as an herbal remedy if it didn't have a benefit, but we need to be able to define what that benefit is and characterize it more completely in order for it to be added back into the pharmacopoeia where it was, up to 1954. Again, additional references that will be provided in the links below, so on botanical drugs, as well as a variety of articles kind of describing the effects of cannabis and the molecules and, different ideas associated with the medical cannabis programs. So thank you for listening to this Ethical Dilemma in Science. We've got one more in this 3-module. Take a look at ivermectin in the next video, and then we're going to have a discussion question based on that. So thank you, and have a great day.